Shall go on to Dr. DEVAPRASAD Gopal, who is a senior consultant in cataract and refractive surgery from Modi Eye Hospital and Prasad Eye Care Center, Bangalore, and is involved in surgical training of students and has a number of presentations to be proud of at the state and national levels. And he is going to talk on a quintessential topic, choice of anesthesia in small incision cataract surgery. And let us hear from him.
Am I audible? Am I audible?
Yes, yes.
Yeah. Good evening, ma'am. Good evening, ma'am. I would like to share my screen right now.
Yeah.
Yeah, at the outset, I would like to thank the All India Ophthalmic Society and the scientific committee for giving me an opportunity to present in front of all the big stalwarts in SICS. Today's my topic is about the choice of anesthesia, which is a very important step in SICS. The history goes back to the ether, which was synthesized in 1540 by the Cordes, but no longer now it is used because it is got a lot of side effects. So chloroform was formed in 1853 by Dr. John Snow. Then endotracheal tube was a very good invention in 1878, followed by thiopental in 1934. So what is an ideal anesthesia? An ideal anesthesia should make the surgery painless, and it should be easy to administer, safe. Akinesia should be there, and it should be comforting to the patient, and the recovery should be smooth. So broadly, anesthesia can be classified into local, regional, and general. We are interested only in the local anesthesia, where we do only topical and infiltration anesthesia. So types of anesthesia, infiltration anesthesia, there are basically three types: retrobulbar, peribulbar, your subterraneous block. Then the most popular topical, along with intracameral and general anesthesia. Coming to general anesthesia, this is reserved for especially for patients with Parkinsonism, congenital cataract, deaf and mute patients, patients who are mentally retarded, psychiatric treatment patients, and some patients who request for general anesthesia in particular. So phases of general anesthesia includes induction, maintenance, and recovery. So this is done by the anesthetist. So the triad of general anesthesia involves hypnosis, analgesia, and relaxation of the muscles. That is muscle relaxation. So what are the hypnotic drugs which we use? The gold standard is a thiopentone, followed by propofol, etomidate, benzodiazepines, and ketamine. Inhalation anesthetics, the most common is the nitrous oxide, followed by isoflurane, sevoflurane, desflurane, and allothane. Analgesia is also been given by giving non-steroidal anti-inflammatory drugs. The gold standard is aspirin, followed by ibuprofen, diclofenac, and COX-2 inhibitors. So also by opiates, in which morphine plays a very important role, followed by fentanyl and remifentanil, which are ultra short acting. So muscle relaxants, generally, they aid in intubation, they help the surgeon, and it also helps if the surgery is of long duration, and it reduces the maintenance dose of anesthetic agents. So the blocks are many types actually, depending on which nerve you want to block, like the supratrochlear, or zygomaticofascian or block, or infraorbital, which supplies a specific region. So first starting, it was widely followed anesthesia is the retrobulbar anesthesia, which was described in 1884 by Knapp. It blocks the ciliary nerves, second, third, and sixth cranial nerves. So it is given into the retroconal space around 3 to 4 ml. It blocks the cornea, uvea, and the conjunctiva, as well as it causes akinesia of the extraocular muscles. So it is not very much famous because it is bound with complications. Around 1 to 3% of complications has been reported in literature. The most common is retrobulbar hemorrhage, ocular perforation, especially in eye myopes and patients with staphyloma, subarachnoid or intramural injection, which is rare, postoperative ptosis, diplopia secondary to myotoxicity, cardiac respiratory distress, injury to optic nerve, and vascular retinal calculations are little rare. So peribulbar anesthesia is the most commonly given anesthesia. It is discovered in 1980 by David and Manda. It is given in the extraconal compartment, 2% lidocaine, 3 to 4 ml, coupled with bupivacaine, which is a long-acting anesthetic, around 0.5%. Usually it is mixed with hyaluronidase, which is 50 units per ml. It can be mixed with adrenaline, which is in the concentration of 1:1 lakh. The main drawback is congenital chemosis and rarely hyaluronic acid allergy. So another very good technique is a subtenon anesthesia, which is described by Stevens in 1992. It is injected into the peribulbar space beyond the equator, around 2 ml of 2% lidocaine. It is less painful, better akinesia. There is very small rise in IOP. The effect lasts for 60 to 90 minutes, and with 4 to 6 hours of postoperative analgesia. So the subtenance is given by a special type of cannula, which is angulated and is not bent at any degree. So the very commonly used is a topical anesthesia, which was reintroduced in 1982 by Finchman. There is no risk of ocular perforation, no injury, no CNS depression, and vision regains immediately. That is the one attractive factor which patients want. So there is another technique described called as no anesthesia by Dr. Amar Agarwal in 1998. It goes with the concept saying that the peripheral and superior cornea is less sensitive than the central cornea. This is because of exposure to UV rays, but it is not gained popularity because it causes increased stress for the surgeon to give best to the patient. So it was now again modified by Carmona, known as cryoanalgesia, in which all the solutions are cooled to 4 degrees Celsius except the povidone drops. So eye mask of cold gel is placed over the eye for 10 minutes and then the surgery is done. Topical anesthesia is the commonly performed surgery. It blocks the long and short ciliary nerves, mesociliary nerves, and coupled with intracameral 1% preservative-free lidocaine. The surgeon's requirements are he should be consistent in surgical outcomes and he should be confident in his surgical skills. Patient selection, you should always avoid anxious patients, avoid those who opt for topical because they're scared of blocks, uncooperative patients, high risk category like the severe bells, respiratory and cardiac, you need to have an anesthetic backup. So advantages is you can operate on a normally pressurized, there's no chances of hypotonia or a or a tight globe due to RVH. It can maintain coaxiality of the eyes, peer pressure to stay in the race because everybody wants no stitchless, painless surgery. And if the patient is requesting for a topical, you need to give him a top benefit. Conclusion. So type of anesthesia depends on the surgeon, okay, and it depends on the grade of cataract. If it's a very hard cataract, better to block the patient. And if the size of the pupil is little small, if you need to use a pupil expander, then better to get the better the eye to be blocked. And patient cooperation is at most needed. Subcutaneous or topical with intracameral lidocaine works well in all cases. So I'll just I'll just 2 minutes. I'll just show you this entire surgery is done at a topical. Intracameral lidocaine is injected, then the stained with trypan blue dye, and it is washed with saline solution, and then AC is formed with viscoelastic surgery. The main idea is to make the AC deep. The AC should never collapse. If it collapses, the patient winces in pain. So always maintain the anterior chamber with a copious amount of viscoelastic. It would be better to use a dispersive viscoelastic agent. Once the rhexis is done, then the conjunctiva, has already been anesthetized by 2 to 3 drops of proparacaine in the beginning of the surgery. So once that is done, congenital peritoneum is done, and then you, as you know, the sclera is little insensitive. You can take a incision of 5 to 5.5 millimeter and then make a sclerocorneal tunnel. Once that is done, then you can enter it with a keratome. Once the keratome we enter, then hydrodissection is done and the nucleus is just delivered into the anterior chamber. Now the time is to remove the nucleus, but you need to inject a lot of visco, protect the corneal endothelium, don't let the AC collapse, and remove the nucleus in one go. And then the anterior chamber is washed with all the remaining epinuclear material and cortex. And then you can actually ask the patient to keep looking at the light. As you can see, this entire procedure is done under topical. The patient's eyeball is not removed because you are constantly telling the patient to focus on the light. Yeah, I'm done with it. And after this thing, you can just inject, you can put viscoelastic at the end of the surgery to place an intraocular lens. So intraocular lens also can be placed very comfortably inside the bag, and it can be dialed inside the bag, and whatever remaining cortex can be washed off in the end. So, and this entire thing can be done at a topical. So topical SICS is the present, and it's going to be the future, and it gives results as better, as good as phaco, and as better than phaco. Thanks a lot, and thanks for the opportunity. Thank you for your attention.
Thank you very much, Doctor. That was a wonderful, very crisp talk and covered everything. Actually, I realized that I do not have effective questions to address because you seem to have covered it all. But having said that, I would want our experts to comment on this. Dr. Ravindra, Dr. Sahu, any one of you, Dr. Deepak Megor, when do you think a surgeon in SICS would need to look at going on to topical intracameral anesthesia? Do you think that's mandated, keeping in view that there is more conjunctival handling and all that? Doctor?
Can I answer this?
Yes, yes, Doctor.
Yeah. See, as far as handling is concerned, the conjunctiva is the tissue which can be easily anesthetized by topical medications. And I mean, it's short acting. It doesn't act for a long time, but you can always add on additional drops to clear it up. I think conjunctival handling is not a big issue as far as anesthesia is concerned. The main issue is the ciliary body, which is painful. Iris and attached to the ciliary body. Whenever you handle the iris and pull the ciliary body or stretch the ciliary body, that's painful. Cornea and conjunctiva being the surface tissues, I think it's not a big issue in considering it. I personally would, recommend all SICS persons, surgeons over a period of time to switch out to topical, which is probably the most elegant way of doing surgery. Not that, injections are avoided. That's one major reason. And that there are a lot of complications that are described because of injection anesthesia. That's avoided. But of course, you have an alternative of subtenon injection, which is prick-free and which is as safe as topical. But then topical means that you're handling tissues very gently, and that's the biggest plus point that I would, insist on. I would suggest everybody to switch over to topical. It's very easy, as Dr. DEVAPRASAD told. It's very easy to switch over. There are a couple of steps that you'll have to look at, and it's a possibility.
Yes, and as far as compared, yes,
yeah,
yes,
I think before a beginner switches over to topical, must make sure that he gets rid of the bridal suture. There is a practice of using the bridal suture as a fixation, but I think that in topical anesthesia would be a challenge, and he should be predictably good in his surgery, completing a surgery in 5, 7, 10 minutes. As Ravindra pointed out, I cannot agree more. In fact, we must now consider, because SICS is also for the masses, a surgery for the masses, that the rate of infection, endophthalmitis, is probably less than globe perforations. So, and globe perforation is such a dreaded complication that you really can't do anything about it. So, yes, topical is the way, and you can always top it up with subtenon if required with an uncooperative.
Supposing you are not doing topical yet, now we know retrobulbar is on its way out. Dr. Paneer Selvam, would you want to answer this? What would your take be on either doing peribulbar or moving on to subtenons? You have to unmute yourself. Yes, Doctor.
We are more comfortable with peribulbar in our institute. We tried the subtenons, but the system has to be adjusted, and the results are the same. So we are continuing with the peribulbar. We don't find any issues with that.
Dr. Deepak?
The issue with the injection anesthesia is, the subtenon scores over other the injections because it's very safer. The safety parameter is tremendous. You're using just a blunt cannula. So even if the first year resident is also giving it, there's absolutely no chance of any globe perforation, any complication. So that should be the single most important reason for us to switch on to subtenons, even when a first year resident does that. I think in the modern era, I don't really justify the use of needles for anesthesia.
Yes, I totally agree on that. And I'm sure places where large-scale surgeries are being done, I think the young PGs are giving, especially I'm sure in Arvind, that's the way it's happening, no? The subtenon, Dr. Revati? Yes.
Yes,
yeah.
Subtenons only.
Yeah. Any other questions, Satyajit, you would want to ask, or shall we go on to our next speaker?
We can go on to the next.